Hello, and we're excited that you have joined us today. I'm your moderator, Faith Rogers with DKB Med. As we start 2022, we've now entered a new phase of the pandemic with Omicron causing more COVID-19 cases than we've ever seen, and hospitalizations are also on the rise. Fortunately, you're in for a great presentation today with our excellent faculty who will do their best to make sense of it all. For those of you that may be joining us for the first time, welcome. If you've participated in some of our over 150 webcasts on this important topic, we welcome you back. We've been developing COVID education since March of 2020, and nearly 2 years later, we're incredibly grateful for all of the progress that we have all made in managing patients during this pandemic. Okay, so here are those great faculty I mentioned earlier. For those of you who have been with us since last year, you'll recognize them. And for our new learners, please meet Dr. Angarone and Dr. Safo. So Dr. Angarone and Dr. Safo, thank you so much for joining.
Happy to be back.
Thanks
Thank
for
you for
having
having
us.
me.
These are our faculty's disclosures today. This educational activity is supported by an independent educational grant from GlaxoSmithKline. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Please note that the material is presented in this program is current as of today, February 3rd of 2022, the date of the recording. So for the most contemporary guidance, please do review the NIH and IDSA treatment guidelines. Today's learning objectives are to describe the mechanisms of action, indications for, and clinical trial data for various monoclonal antibodies under EUA investigation for treating COVID-19. We're also going to appraise the best opportunities for application of monoclonal antibodies to treat patients with mild to moderate COVID-19, and describe the effect of specific viral variants on monoclonal antibodies. I will hand this back off to Dr. Safo as she presents a case to us.
Thank you. Hi, everyone. So we're going to be talking today about Omicron and the therapeutics that are able to appropriately treat it. And to kind of ground us in the real world, we wanted to present a patient case of Bob and Janet. So Bob is a 70-year-old man who was evaluated at the primary care clinician's office, and he has a history of lung cancer for which he's receiving radiation and chemotherapy. His symptoms are sore throat, cough, and fever of 2 days duration. His O2 sat on room air is 96%, and his nasopharyngeal swab for SARS-CoV-2 is indeed positive. So that's Bob's situation. But Bob also has a sister, Janet, who is 68 years old and she lives nearby. She's a patient in the same office and she's been fully vaccinated, including her booster, but she has leukemia and is immunosuppressed. She's not visited her brother or seen anyone in months apart from kind of essential travel like going to the grocery store, etc. So keeping Bob and Janet in mind, we wanted to speak to you today about what was happening with SARS-CoV-2, specifically thinking about the new variant with Omicron. And so the emergence of Omicron kind of brings us to a place where we have to really think about what we know that works for COVID, what we are developing against COVID, and hopefully what is kind of going to be the preference for how we treat COVID, which is preventing individuals from getting infected anyway through vaccination and other measures. And so talking about Omicron, which is known in the literature as B11529, for the US, our timeline kind of happened towards the end of November. And many of you will remember as we geared up for the holidays, news of this new variant. So November 24th, 2021, the World Health Organization reported its first case. And those cases were coming out of Botswana and South Africa. November 11th, Botswana, through its detection mechanisms, reported that they found a new variant of concern. November 14th, South Africa did the same. What is interesting with this identification here is that these are areas, because of HIV and other infectious diseases, that have a very robust genomics sequencing program throughout the country. And so they just happen to be kind of ahead of the curve in really being able to find this variant and sound the alarm. And they were able to kind of get the world ready. Once we were primed and looking for this, many other places found this variant of Omicron very, very quickly. November 26, 2021, the current variant B11529 was designated as Omicron and was designated as a variant of concern by the WHO and the US SARS-CoV-2 integrase group, SIG. And so by the time that that happened, many public health bodies around the world were preparing for what was looking like it was going to be a major surge. By December 1st, 2021, the US had identified its first case in California. We'll talk about some of what happened pretty quickly after that. What is very interesting about Omicron, and this graphic from the CDC is one that's really important to take a look at, is the rapidity of it taking over as the predominant case or variant of SARS-CoV-2 that we were identifying. If you look at the kind of bottom of the slide, you see that in about October, we were looking primarily at SARS-CoV-2 that was B16122, which was the Delta variant. And that had been predominant pretty much up until November, through November in the US. And what you start to see starting in early December is the kind of purple that comes in, and that's Omicron. So yellow is Delta, purple is Omicron. And you start to see that at first it makes up maybe 60% of cases. And within the span of 1 week, it starts to make up about 80% of cases. And then over time, by the time we hit January, Omicron is a predominant variant that we are seeing in many, many places. It is worth noting that there is a time lag in this or rather a geographic lag for different areas. There are some areas who experienced this kind of oversurgence of Omicron very early, like the Northeast and the Mid-Atlantic regions. And there are others that kind of lagged behind a few weeks, and those tended to be kind of the Midwest, Southern regions. And that has to do a little bit with the epidemiology of how the virus was able to, how this latest variant rather was able to spread. And so from there, what we kind of saw was a tremendous impact on the 7-day average of cases, tests, hospitalizations, and deaths. And so let's kind of go through this. So over the summer months, we saw, I'll kind of start from the middle. If you remember, after we did a series of campaigns around vaccination, we saw a blip with the Delta variant from about June to October. And before that, going from about October 2020 to about February 2021, this was really pre-vaccination of a tremendous amount of the population. We had seen a blip in cases then as well. And so if you kind of acknowledge those two times as, two of the surges within the US's experience of this pandemic, and then you move over towards the end of this graph and you compare what has happened with Omicron. And, we talked a lot in the beginning of this pandemic about flattening the curve. And people have joked that Omicron in some cases did flatten the curve. It just flattened it along the y-axis, because what you can see happening starting from November 2021, is an incredible increase in 7-day average of cases. So fast that it completely obliterated the number of cases that we were seeing again in our prior to kind of closer surges that we had observed. And if you go down to the lower graphs in gray, what you're seeing is what we've learned about COVID, which is what happens around testing, hospitalization, and deaths. And so testing increases as we see an increase in cases. People have symptoms, they go in and they get tested. Hospitalizations lag slightly. They lag for about two to 3 weeks. And that's in part what we've kind of expected to see. With Omicron, there's some interesting data around hospitalizations because people are vaccinated, and the immunogenicity seems to be a little bit different with this variant. And so the hospitalizations have been a little bit different than we had expected. But again, there's that slight lag in hospitalizations. And then same thing for deaths. You'll see deaths kind of trend up with each surge that you have. And so Omicron, for the most part, kind of followed what we had seen in prior surges. But the kind of takeaway from here is that it was so significantly exacerbated in terms of the number of cases and the kind of response that it really did elicit among the population. And it's worth talking about why that happened. And so we have all heard, probably ad nauseum, discussions about different parts of SARS-CoV-2 virus, specifically the spike protein. So if you take a look at Delta, you take a look at Omicron, Delta was, before Omicron, the variant that we all talked about. And we talked about it because there were mutations in the virus that allowed it to be more severe, more infectious. What is very interesting about Omicron is that it carries over 50 mutations, and over 30 of those are in the spike protein. And the reason why this matters is that the SARS-CoV-2 receptor that allows it to have a binding domain to enter the human cells, and these cells are the ACE2 receptor cells, that happens through that specific area with the spike protein. And it's very important in order for it to enter our bodies through the nasopharynx and lungs for that spike protein to be able to kind of evade our previous immune response. And so Part of the reason why COVID has been so deadly is that no one before, December 2019, when it was first identified in China, had ever seen this particular form or version of the coronavirus. And so there was no way to have your body provide immunity. Over time, because individuals have been infected with COVID and because individuals have been vaccinated, there is quite a good amount of protection when you do see the latest version of SARS-CoV-2 virus. However, Omicron's mutations, again, over 30 mutations in the spike protein area alone, has had real impact, because what it has meant is that it has allowed this current variant to actually evade our current defenses, which include neutralizing antibodies and T-cell mediated response. And again, that hasn't been kind of across everyone. There's some folks who have still mounted a very good response, but this is why that previous graph that I just showed shows such a dramatic increase, is because this current variant has really been able to evade the way that we have offered protections historically. And so we've learned quite a bit, and we want to turn to a case study, a case series of a cohort that tells us a little bit more about what happens when populations are infected. As I mentioned, the first case of Omicron was detected in the US on December 1st, 2021. That was a fully vaccinated individual who had traveled to South Africa, come back into California November 22nd, and started developing symptoms, went to the hospital, and was identified to have Omicron. And the person ended up having a very mild course, but that was the first kind of case that we saw. And what Kaiser Permanente's health system did was actually take a look at all of its its COVID cases from about November 30th all the way through December, to understand what happened as this new variant really took over. And they did genomic analysis. And what you'll see here with the gray and the pink, let me orient you, where it says SGTF, that denotes S gene target failure, which is a proxy for this new variant, Omicron. And no SGTF is kind of all other cases, or predominantly Delta. And so over this time period of about a month and change, they found about 52,000 cases of Omicron, and they found about 16,000 cases of Delta. And what you can see is there's that kind of inflection point where if you look at about December 14th, the Omicron cases start to rise and kind of continue to rise. And so what this study did was to really try to understand the natural history of Omicron infection for those who were all comers, vaccinated, unvaccinated. And there's some very, very interesting results that we can get into that I think has led to the lay phrase that quote unquote Omicron is mild, or Omicron hasn't been as deadly as other versions of Delta, of COVID rather, that we have seen. And so in this slide, we can kind of talk about what we saw by numbers. And so of the 52,000 individuals who had Omicron among this study population, among this population, they found that about 235 of them ended up being hospitalized. And those who had Delta, the 16,000 who had Delta, about 232 were hospitalized. So the percentage for those populations is only about 5.5%, 0.5% of individuals who had Omicron ended up being hospitalized, and about 1.3% of individuals who had Delta ended up being hospitalized, which is a 53% risk reduction for Omicron cases versus Delta cases for hospitalization. And what you'll see in these graphs are further indications, again, of the reduced severity of Omicron compared to Delta. For ICU admissions, that was 74% risk reduction for those who had Omicron versus Delta. Mortality was reduced by 91% for those who had Omicron. Mechanical ventilation, no individuals who were diagnosed with Omicron ended up requiring mechanical intervention. And those individuals who did go to the hospital with Omicron, who needed a hospital stay, stayed for about 3.4 days shorter than those who had Delta. And so it's from studies like this and this kind of evaluation of these populations of comparing Omicron to Delta that allowed us to understand that truly it seems as though from a population perspective, that individuals who were getting Omicron, especially those who were vaccinated, seem to do fairly well in terms of their disease course, in terms of needing hospitalization, mechanical ventilation, and then progressing through to death. Omicron overall seemed to be less severe than previous cases of COVID that we had seen. It's important to note that while that is the case, not all populations are the same. And so those who are high risk, and we can look at populations like pregnant individuals, populations who are immune compromised, et cetera, regardless of the variant of COVID that they're getting, there's still very, very major concerns that their disease course will not be quite as mild, quote unquote, as other individuals who may not have some of those risk factors. And this brings us to a place of really thinking about what we know about the clinical progression. And so I'm going to offer you some guidance for what we understand pre-Omicron and kind of what we've learned through Omicron that has changed. And so we know that with previous versions of COVID, that when you're exposed, it's anywhere from a 3 to 4 day incubation period before you start showing symptoms. Your symptoms will be fever, cough, malaise, dyspnea, or can be pretty mild. Some individuals around day 7 onward may actually get worse. So those are the individuals who will have respiratory failure, hypotension, sepsis requiring hospitalization. They may go into the hospital, progress to ARDS, require mechanical ventilation and an ICU stay, and kind of things progress from there. And if that isn't the kind of progression, what will happen for most individuals is that by day 10, you've experienced this disease and you're better, and you're also no longer infectious. And that infectious period is incredibly important because that's been some of the conversation we've had in the public health world about when people can kind of be around other individuals once they've had COVID. There's a caveat on all of this that if, for individuals who are immune suppressed, there is a difference in our understanding of how long the disease course can remain. For some individuals, this can be up to 3 to 4 weeks or longer, and those individuals can actually remain infectious. And then so where kind of Omicron lays over on this is that Omicron's incubation period was much shorter, it was about 2 days. And its symptoms when it did present was anything from sore throat, headaches, fevers. It didn't have quite as much of the lower pulmonary symptoms that we had seen with Delta and other versions of COVID. The progression of symptoms seemed to take about 5 to 7 days. Again, previous versions seemed to take anywhere from 5 to 10 days. And because individuals with Omicron tended to be, because we vaccinated over 70% of the population, individuals with Omicron tended to be closer to or more likely to be vaccinated. There was the kind of belief that if after 5 days, most people are feeling better, they should be able to kind of come back out of isolation and shouldn't be infectious. There's many, many caveats to that, but really the takeaway from here is that what you're seeing on here, which is the clinical course of COVID-19, Omicron has kind of compressed and shortened it along the way. With that in mind, it means that the times that we have, or the time that we have to give the therapeutics to help for those who are going to have a severe progression of disease is also shorter for Omicron. So antivirals and monoclonal antibodies are all medications that are really given in that outpatient early period of infection before individuals get much sicker and end up in the hospital and then need, again, immune modulators. So keeping that in mind, you can kind of, remind ourselves of what we know about COVID-19's clinical course, that most individuals will have mild to moderate symptoms, about 81%. Some will have severe symptoms, which is like dyspnea, hypoxia, again, bilateral involvement of the lungs leading to ARDS, about 14%. And some individuals will be critical, experiencing shock and multi-organ dysfunction, about 5%. Those numbers, again, are somewhat attenuated with Omicron. And for those who are vaccinated, hospitalizations have changed. And so individuals that are vaccinated who have breakthrough COVID are only hospitalized, or of that population, only about 2% of those individuals need to be hospitalized. For individuals that are not vaccinated, though, that's as high as 10%. And that number is even higher if you're not vaccinated and you're older. And so this is where a lot of the push from public health officials and clinicians continues to come from, is that we know that there's such an impressive difference with vaccination status on the clinical course of disease. And there's an understanding of who those high-risk individuals are according to different levels of data. So we've used meta-analyses in some cases, cohort studies, case series studies, but we have a sense that those individuals who are at high risk for severe disease include individuals with cancer, cerebrovascular disease, CKD, COPD, those with certain lifestyle challenges like smoking, individuals who are obese, individuals who are pregnant or recently pregnant, and those with diabetes. And then there's some special disease states, again, that we tend to have kind of expected and that we have seen pan out have slightly worse courses or be at risk for severe disease. And that includes individuals who are on immunosuppressive medications, those with sickle cell disease, those with HIV, which is the population that I work with. And then there's some mixed evidence around what happens with those with asthma, hypertension, and other immune deficiencies. For the most part, though, there is an understanding that chronic illness sets you up for potential more severe disease course with COVID-19. And we can really see that in this risk of death analysis that we can look at both by age and comorbidities. And so it is now a common and accepted knowledge that as you get older, your chances of dying from COVID do increase. And so those who are younger, as you can see, chances of mortality from COVID goes anywhere from about 2.2 all the way up to 10. And so what is so interesting about that is that it's just a straight correlation. The older you are, the higher your chance of complications from COVID-19. And so it is part of the reason why, vaccine rollouts happen first for that age population, boosters are encouraged for that population, and we kind of keep a particular eye. The impact is a little bit less stark if you look at certain comorbidities, including diabetes, chronic kidney disease, COPD, neurocognitive disorders, etc. And that relative risk is anywhere from 1.1 to about 1.2, 1.3. Again, what really is interesting about this is that if you start to add the factors together, so someone who is both older, let's say 65 and up, and has at least one comorbidity or more, then their chances again of death from COVID, including from Omicron, can really be increased. And the kind of final graphic at the bottom of this slide really illustrates that those who have no additional chronic conditions are at a baseline risk. And as you add on the numbers of chronic conditions, your risk of death once you contract COVID increases quite significantly. So we want to kind of draw your attention to, I think, a very important point to make as we talk about this, which is that we're defining risk by disease state and by age, and it's very important to also define it by race and ethnicity. We learned early on in the pandemic that those who are from different racial and ethnic groups had different experiences across chances of catching COVID, so cases, chances of going to the hospital from COVID, and chances of dying once in the hospital. We really want to draw your attention to these kind of four examples, with the comparison group being white, non-Hispanic individuals. If you look particularly, I'm going to call out American Indian, Alaska Native, and Black or African American. You'll see here that in terms of cases, at least for African Americans, while that's gone down to about close to what the references group is, there's quite an increase in cases for other populations like American Indian and Hispanic or Latino. For hospitalizations and death throughout the pandemic, that has remained high for these high-risk groups. And it's anywhere from as twice as likely that individuals will be hospitalized to 3 times as likely. And of course, we want to look at death. The rate of death for high-risk groups can go up as high as 2 times likely than the reference group if you're Black, American Indian, Alaska Native, or Hispanic or Latino American. And so that kind of brings us to an interesting correlate of, well, what happened with Asians who are non-Hispanic? And, this is where I think there's a real story around vaccinations, because that difference, we believe, is being accounted for by the tremendous uptake of vaccinations among this population. And so you'll see in this slide that while the majority of the population is anywhere from 54 to 60%, and so I'll kind of take you through this bottom number here, are Black Americans. The second line from the bottom are Hispanic, and the third line up are white Americans. That line that rises up, it's the light blue, those are Asian Americans. And so they are, about 20 percentage points above most of where other populations are. And we believe that does attenuate their overall risk from cases, hospitalization, and death. What is interesting also about this graphic is to see the ways in which vaccine uptake has actually improved over time. And so what started off as pretty significant differences by race, if you take a look into April 2021, you can see that the differences, the kind of gaps by racial group were really, really wide. Over time, through the work of different advocates, different policy measures, etc., we have been able to slightly kind of reduce those racial and ethnic gaps. The hope now is that we can actually take all the three groups on the bottom and really increase them up to where we have our Asian American group at, because the kind of widening has really started to have this curve get a bit stagnant. And as I've shown you guys from earlier, vaccinations and preventing infection is one of the best tools that we have in our toolkit as we kind of prepare for what may be the next wave and the next variant that may come down the pike. And so with that, I'm going to turn it over to my colleague, Dr. Angarone, to go ahead and tell us a little bit more about antibody treatments.
Thank you, Dr. Safo, for that, I think, wonderful overview of Omicron and the impact that Omicron has had on SARS-CoV-2, on COVID, on our patients, and how we really kind of look at this infection now. And then I really like the overview of some of the epidemiology, especially the differences between different ethnic and racial groups regarding infection and vaccine. So now we'll move on to antibody treatments. And so antibody treatments have really been the mainstay of our outpatient armamentarium and what we've really used to help keep people out of the hospital. When we think of the antibody treatments, I think it's most important to start thinking about the treatments as how they work, how they function, how they're created. And really what we're going to be focusing on are the monoclonal antibodies. And so these are antibodies that have been developed to target specific aspects of the spike protein. Each one of these monoclonals that are listed on this slide bind to the spike protein, but bind in a slightly different way with different affinity or other different features in the antibody. But I think it's important to remember these are manufactured to be the same. The Bamlanivimab product is the same throughout all the different doses, the Casirivimab, the Etesevimab, etc. Much different than the convalescent plasma that we were talking about, I think kind of earlier in the pandemic, which is collected plasma from individuals who have SARS-CoV-2, and then we kind of purify or isolate the antibodies against SARS-CoV-2, but they could have all different types of binding affinity and binding characteristics. So I think this is what's really important about these monoclonal antibodies. Another aspect that's extremely important about these antibodies is how do we utilize them? How do we think about them when it comes to treatment? And we often think about monoclonals or any sort of antiviral medication as kind of the right drug, right time, right patient. When we're thinking about the patient, we want to be able to select those patients that are going to benefit the most from our treatment. We know, as Dr. Safo reviewed, that 80% of the individuals that become infected with SARS-CoV-2 are going to have a mild course. They're not going to come to the hospital. They're not going to need hospitalization, and they're going to get better without treatment. The problem is how do we identify those other 20%? And then it becomes really critical to try to get those individuals into therapy as soon as possible. So these monoclonals, as well as some of the antivirals that are being looked at, timing is critical. Getting the treatment to the patient as soon as possible. And then we also have to realize that some of those individuals that we treat, their illness will continue to progress no matter what treatment that we've given them. And this becomes really difficult when thinking about what patients should we target for therapy. How do we decide which patients we should prioritize? Should we just give it to every patient? And we'll talk about that in a bit with the monoclonals, how the CDC, the FDA, and everyone that's practicing is really trying to hone in on who's going to benefit the most from these treatments. But we also have to take the virus itself into consideration. So viruses replicate very quickly. Each one of us that becomes infected can have millions upon millions upon millions of viral particles within our system, within us, and that leads to changes and mutations in the virus. And so within a community or different communities, there may be monoclonal antibodies or treatments that work in some areas and they're less effective in others. There's escape mutants that can develop. So Dr. Safo mentioned caring for HIV or other immune suppressed, especially in light of Omicron kind of being first recognized in South Africa, where you have a lot of individuals with HIV infection. Immune compromised individuals can harbor the virus for longer, and that virus can replicate for longer. So within an individual, you can get changes, which then can translate into changes throughout the communities themselves. So these become very critical, very crucial aspects to treatment, and to remember how effective and how meaningful these monoclonal antibodies may be. And this can be seen when we start talking about the variants and what we've learned from the variants as we've really started to track them, I think, much more effectively over the past year and a half. And so we can see all the antibodies that have been approved through FDA EUAs: the Bamlanivimab, Etesevimab, Casirivimab, Imdevimab, the Sitorvimab, and then the Etesevimab, Silgavimab antibodies. All were effective against alpha. We lost Bamlanivimab, Etesevimab with beta and gamma, and many of you may have experienced kind of the restriction on usage of the Bamlanivimab, Etesevimab, kind of in the late winter of 2021 into the spring of 2021. And then we had Delta. And so as Delta arose, we were worried about Delta, concerned about Delta, but all the monoclonal antibodies actually had some activity, and we started to see a return of the Bamlanivimab, Etesevimab, as well as the others. Omicron has really changed this in that the antibodies we were using the most, the Bamlanivimab, Etesevimab, and Casirivimab and Imdevimab, have no activity against this variant. And we're really left with the Sitorvimab as therapy, and then the Etesevimab and the Silgavimab as kind of a pre-exposure prophylaxis or passive immunity, which we'll talk about in a bit. I think this is a great resource for anyone out there that's practicing, that wants to know, can I use an antibody in my area, or are we starting to see variants where these monoclonal antibodies may not be as effective? The link that's on the slide, the opendata.ncats.nih.gov, has a nice tool where you can really see the effectiveness or lack of efficacy of the monoclonal antibodies against different variants. This is Omicron with the monoclonal antibodies that are either FDA EUA approved or are in study, and you can see that the Sitorvimab still has activity, but when you look at antibodies like the Bamlanivimab, Etesevimab, there's really no activity. There's a loss of activity against the virus itself. And so this is a nice resource for those of you that are practicing, that want to know, can I use the monoclonal antibody in my area? So even though some of the monoclonals that we utilize are no longer recommended, I think it's important to talk about the data behind these antibodies and what effect these monoclonal antibodies have had. And so we'll start with Bamlanivimab, Etesevimab. This antibody combination was studied in BLAZE-1, which was a phase 3 randomized controlled trial in mild to moderate COVID-19 individuals. There was around 1,000 patients within this study. They were randomized to the monoclonal antibody or to placebo. The population was diverse, with 29% Latinx and 8% Black. Median age was 56, with 31% over the age of 65. The main outcome was hospitalization or death after receipt of the monoclonal antibody. And we can see that the Bamlanivimab, Etesevimab resulted in a 70% reduction in hospitalization or death within 28 days after receipt of the antibody versus placebo. So 7% in the placebo, 2% in the Bamlanivimab, Etesevimab. There were no deaths in the treatment arm. There were 10 in the placebo arm. And there was also a greater and more rapid decline in the virus levels within the treatment arm as well. This monoclonal antibody combination did receive FDA EUA at the 2,800 milligram dosage. A lower dose was studied, but that is not authorized for treatment. And right now, this antibody is not recommended for treatment because of its lack of efficacy against Omicron. But again, the data for this antibody shows that these antibodies are effective against SARS-CoV-2. Another monoclonal that we've seen is Casirivimab and Imdevimab. Again, a large phase 3 trial of around 4,000 patients that were at high risk for complications related to COVID. Over 50% having obesity, over a third with cardiovascular disease. Again, a population that had that was diverse with 35% Latinx, 5% Black. Again, the main outcome of the study was COVID-related hospitalization or death within 28 days of receipt of either the treatment or placebo. This study was unique in that it looked at 2 different doses of the Casirivimab and Imdevimab antibody, 2,400 milligrams or 1,200 milligrams. Both doses were actually found to be effective at reducing COVID-related hospitalization or death. So both were 70% effective at reducing that primary endpoint. And they also reduced the time to symptom resolution from 14 days for placebo to 10 days with the monoclonal antibody compound. And so this monoclonal antibody did receive EUA approval. In the summer of 2021, that EUA was modified to reflect the lower dose, the 1,200 milligram, as well as state that it's okay to give the lower dose subcutaneously as opposed to IV. And this is really important in places that IV is not feasible or that would delay treatment. Again, this is unlikely to be effective against Omicron and is currently not being distributed because of Omicron. But we are left with Etesevimab. So Etesevimab does have activity against Omicron. This is the monoclonal antibody that is being distributed by the CDC and the FDA to various states for administration to our patients with SARS-CoV-2 infection. Received an EUA in May 2021 based off of the interim results from a phase 3 trial of around 580 high-risk patients, again, over 50% with obesity, a diverse population with 63% Latinx and 7% Black. The outcome being hospitalization or death within 28 days of receipt of product. And the Etesevimab was demonstrated 85% efficacy at reducing hospitalization or death. It was 7% in the placebo arm and 0.8% in the Etesevimab arm. What's interesting, this antibody, the company that manufactures this also looked at the potential mechanisms for how these antibodies are working. And the 2 hypothesized mechanisms are blocking of viral entry into cells and clearing infected cells from circulation, both of which reduce the viral burden, thus reducing the progression of the infection and the development of the more severe symptoms. And as Dr. Safo mentioned, there's that early phase, but also a secondary phase that occurs maybe about 5 to 7 days after the symptoms begin with SARS-CoV-2. And in this study, the Data Safety Monitoring Board actually converted the placebo arm to an intervention arm because of the lack of efficacy of the placebo. It's being studied with other monoclonal antibodies to see if there's enhanced activity, especially enhanced activity against different variants, and the Etesevimab is recommended for Omicron and is what we're giving our patients currently. So not only do we have some of these studies that are the clinical trials, and many of us think those are the gold standard for showing that therapy is effective, but they also are highly controlled, and patients may be very specific, fit very specific parameters, and sometimes may not mirror what our experiences are in the clinic. And there have been a few studies demonstrating the real world experience with these monoclonal antibodies and how effective they can be. This is one of those studies here on this slide. This is a single center cohort study from February 2021 that was published in Open Forum Infectious Disease at an urban center with a population of about 500,000. About 56% of the individuals in this population were non-white, 23% had a lower poverty rate. The patient looked at individuals with COVID-19 who visited an outpatient clinic or medical center. Around 600 patients, 39% Hispanic, were seen in this population. 45% were eligible for or received monoclonal antibodies, and they were compared to a historic control that did not receive monoclonal antibodies and was obtained from a population before the monoclonals were even available. There were no differences in gender, race, ethnicity between the treated and untreated arms. And what this study showed was that there was a reduction in ED visit or hospitalization within 30 days in those that received the monoclonal antibody versus those that did not. So 12% in those that were untreated and 1.9% in those that were treated. And when adjusting for age, gender, comorbidity, the risk of ED visit or hospitalization was 82% lower in patients who received monoclonal antibodies. It should be noted, and an interesting fact of this study, as well as some of the other studies with real-world experience, there were higher rates of medical visits in the untreated group than in the clinical trial for Bamlanivimab that was in the placebo arm. So potentially altering these results, but I think more reflecting our real-world experiences and our clinical experiences with these antibodies. So when thinking about monoclonal antibodies, as I mentioned earlier, we have to think about these as antivirals, and the key is to get individuals into treatment as soon as possible. So the earlier after onset of symptoms, the better. And hopefully if you're using testing to get people into therapy, you try to get them tested as soon as possible so they can qualify for the monoclonal antibodies. The EUAs for these antibodies are for outpatients only, specifically those at high risk for COVID complications, 12 years or older, with the exception of Bamlanivimab, Etesevimab, which is for all ages within 10 days of onset of symptoms. You want to monitor individuals after administration of this product, and you want to have access to emergency medical services if a complication or reaction should arise. When looking at those individuals that fall into those high-risk groups, very similar to what Dr. Safo had talked to us about, those with conditions that put them at risk, older age, multiple medical conditions, pregnancy, obesity, and these factors change periodically. So I would definitely recommend keeping up with the CDC and FDA recommendations on who falls into that high-risk category. One last aspect with these antibodies is pre-exposure prophylaxis. So this is Etesevimab, Silgavimab, combination antibody that was studied pre-Omicron in about 5,000 unvaccinated patients to see if it could prevent the development of infection. So given passive immunity to these individuals. And what was found was that there was a 77% reduction in symptomatic COVID-19 and a 77% reduction for symptomatic COVID-19 or all-cause death in those that received this antibody versus those that received placebo. And this effect lasted for about 6 months. And there was an EUA that was recommended or put forth by the FDA in December 2021 for this product to be used in anyone 12 years or older expected to have an inadequate response to vaccine or history of reaction to vaccine, and they cannot receive the vaccine, and it's not indicated for treatment or post-exposure prophylaxis. This is pre-exposure prophylaxis. So with that, we'll return to our cases. And so, Dr. Safo, I'll kind of turn Bob over to you. So Bob, our 70-year-old with lung cancer who comes in with upper respiratory viral symptoms, it's tested positive for SARS-CoV-2. What are your approach to this, or how do you approach treating this, and what are you going to do for this gentleman?
So it matters that we have Bob in, given how high risk that he is. it matters that we understand two things about him. One is his clinical risk of severity if we allow COVID to kind of progress, and we can tell with active cancer that is being treated with radiation and chemotherapy, he is someone who is very, very high risk. It also matters that we understand from Bob how long he is into his course. And so we said here that it's about a 2 days duration. We've been able to confirm it with PCR that he does indeed have COVID. And so there's two factors here that we have to think about for Bob is one, that he is someone who could have very severe disease if we don't intervene. And two, that timing really matters. He's early on in his course. And so when I see patients like this in my outpatient clinic, I really activate our protocols right away. And there's two things that we can kind of go to, and I think you really touched upon them nicely. One is monoclonal antibodies, Etesevimab, and you've made the point that we had a real kind of repository before, and now we have really only one, which is Etesevimab. That kind of decrease means that in my hospital system, we have to check availability first before we're kind of sending patients over to the infusion center to get these. The other thing that we do have is Paxlovid, which is an antiviral that we can use early on that does have, as you've mentioned, real efficacy. Again, there is the question of supply for this, and so the way that we have looked into this in our clinical system is to actually work with the Department of Public Health, who is getting the supply and then dispensing it to individuals that need it. There is a delay and a wait, and so I think for Bob, what I would do is I would try to figure out what can I get him as fast as possible. And how do I kind of let him understand what he should be looking out for as his disease course progresses, whether he gets treatment or not. I want to make sure he knows when to come back to the ED, if he continues to get worse with his COVID infection.
Great, and that's, I think, the approach that many of us are trying to look at is how do we get these antibodies for patients, and how do we get them in a timely manner. We have the second half of our case, which is Janet, Bob's sister, who has leukemia, is immune suppressed, and is vaccinated. And this is a patient that in my practice I actually see very commonly. So I'm infectious disease. And I primarily take care of immune suppressed patients. And this is the type of patient. So Janet would be the type of patient that we try to give the combination monoclonal antibody for pre-exposure prophylaxis, so that passive immunity. Unfortunately, there's a limited supply, and so we're working as hard as we can to identify those patients that are going to benefit right away, and then start going down that list. And we've worked out a system to try to really get those patients into the infusion center so we can get them their antibodies. And some of the patients we consider are, like Janet presented here, leukemia on chemotherapy, immune suppression, agents like rituximab that are going to really blunt that immune response for the patient, and the vaccine may not be effective.
Dr. Angarone, I think that that's really smart because I think there's a proactivity about this. We're at the point in COVID where we've been so reactive. Something happens, we react to it. We've learned that we really need to be proactive. And I think having a pre-exposure prophylaxis as one of the tools that we can use is tremendous. There's the question, though, and if we go to the next slide, there's this question that I think we're all faced with of like, how do we know where to find things? And so we wanted to share one tool with you all, which is the DHHS Therapeutics Locator, that across different geographic areas can kind of tell you where you can find different therapeutics. It's important to note, at least I'll speak for kind of us in the East Coast, that our public health agencies really have the most up-to-date information. And so even more than this, going over to your local public health agency, I think will really tell you what's happening around what is available in your local environment. And I don't know, Dr. Angarone, if you'd have any other resources that you might suggest.
Yeah, I think this is a really great resource if you don't work at a center that has your own supply of these antibodies or treatments, or if you're really relying on the Department of Health to kind of point you in the right direction of where to get your patient these supplies, and to be in contact, I think, with your Department of Public Health. I think if you're seeing a lot of patients and you really want to get them into care, talking to your Department of Public Health and saying, where can I send my patients to, or whom is going to be delivering these antibodies? I think it's really important.
Absolutely agree. And the next slide, I think, makes a final point, which is a very, very important one, which is that While we know that we have these medications available, there are differences that are happening according to who has access to them. The biggest takeaway that I think both of us have tried to leave you with is that it matters that you understand the patient's level of risk for progressing to severe COVID, and that the patients present early to get these therapeutics. So what you're looking at here is our understanding, actually, over looking from a period of November 2020 to August 2021, of the percentage of patients who are receiving monoclonal antibodies by race. And the takeaway here, the kind of dark black line you see on the left-hand side, are white patients, and the others are other historically minoritized groups below there. And that difference is very, very major. It's up to about 58% for those who identify by ethnicity as Hispanic, and about 20%, 20 to 25% for other racial groups. And so there are major racial differences in access to monoclonal antibodies. As we've just explained to you, monoclonal antibodies are some of the best treatments that we have to prevent progression to severe COVID, hospitalization, and death. And so as clinicians, I know that both, I can speak for myself and Dr. Angarone, there's a real advocacy point here, where if you have patients that are high risk, you have to really make sure that, one, they know what to do if they get COVID; two, they can access you to tell you that they have COVID; and three, that you can advocate to get them into the places where they can get these resources. And you want to particularly look out for your patients who have some, social determinants of health that may disadvantage them: educational status, employment status, race or ethnicity, etc., because the data are showing us that there are differential rates at which we're giving these life-saving therapies. And Dr. Angarone, if you would add anything else and then take us through the cases as we wrap up.
Yeah, I think that's a great point. And this slide is really important. Our study that we did with the monoclonal antibodies here at Northwestern, we did a follow-up evaluation of those that were recommended for therapy but did not receive it. And one of the major factors that we saw was based off of ethnicity, race, and where they lived in our geographic location. And there's so many factors that play into that. And so I think really developing programs or resources on how can I get my patient to my center or the center where they need to get those antibodies infused, I think is really important as we move along with the pandemic. And so, I think, what Dr. Safo mentioned with these kind of determinants of who's getting these antibodies, I think it becomes really important. That burden is on all of us as practitioners.
Thank you so much to both of you for helping us with those questions. As a reminder to our learners, to submit a question for upcoming webinars, please click that Q&A button to the left of your console. We'll try to get to as many as time allows. So I'm going to ask the first question, which is, what do we know about the relevance of the B2 subvariant of Omicron?
So that's an interesting question. And very much like COVID, we are learning in real time. We understand that this particular variant probably causes as severe of a disease course as the initial B1. The difference here is that B2 seems like it may be even easier to transmit. And so where that kind of brings us is to a place where we're trying to understand if individuals who have already gotten Omicron, are they able to get it again? For individuals who haven't gotten Omicron, I would say the B2 variant or a subtype really tells us that you want to make sure you're wearing very good masks, and you want to try to be doing as many kind of protective measures as you can, avoiding large crowds, etc., because this latest version of Omicron seems to be even more infectious than the previous version.
Fantastic, thank you. Our next question, do we know anything yet about immunity acquired through infection with Omicron versus immunity required from infections with other variants?
So this is, I think, another really good question as well. And we're going to learn more about this as we kind of get a little bit past the Omicron surge that we're seeing. What we have learned is that prior infection and vaccination, or vaccination and then prior infection, really kind of boost our immune system and makes our immune response a lot more robust. We expect to see that with Omicron. I don't expect to see anything different with that. I think what will be interesting to see, as Dr. Safo brought up, will immunity to one Omicron lead to immunity to any subvariants of Omicron or will it change the infectivity of the virus? So I think it remains to be seen. If it follows what we know, we should see kind of that boosting of the immune response, even with Omicron infection.
Fantastic. Thank you. Looks like we have time for one more question. So here it goes. Does Omicron lead to longer lasting infectious period? Seeing lots of people who remain positive on rapid antigen tests for more than 10 days.
So that isn't actually what we are understanding from the population level data. I think what the reason why that question might be coming up is because Omicron has come to us at a time where many people are getting at-home tests, so lateral flow tests or other tests at home, where they can actually follow in serial what's happening through the course of their infection. For many people, we believe that the infectious time period for Omicron is probably somewhere from 5 to 7 days. That is not the case for everyone. And so, contrary to maybe what you've heard from public health sources, the kind of best advice we can give is that if you have Omicron and it is past the 5 days or past the 7 days, it's worth getting retested before you come out of isolation, because you might still be infectious in that setting. Infectiousness you can kind of pick up by your at-home tests, which if it's still positive, we say yes, you could probably still could be spreading Omicron to the next person. So again, we don't think that it's so much that Omicron lasts for longer. I think you're at a time period where many people are probably testing more than they have historically in previous cases of variants with COVID. Dr. Angarone, would you add anything to that?
Yeah, I think that's a perfect way to look at it. Now that we're testing more, we're probably just picking up more people in that post-symptomatic phase of the virus, and I think we really need to get more information. But the information and recommendations that you put forth, Dr. Safo, I think are totally appropriate. Get tested.